Good evening, everyone. I am Dr. Vaishali Gupte, Director Medical at CIPLA, and it gives me great pleasure to welcome you to this webcast titled Pearls of Wisdom, Case-Based Discussion on Management of Bronchiectasis. This is being held on occasion of World Bronchiectasis Month. World Bronchiectasis Day was recently celebrated on 1st July 2022 and will be observed every year on 1st July. It aims to raise global awareness of bronchiectasis, exchange knowledge, and discuss strategies for minimizing the bronchiectasis burden on patients and their families worldwide. Bronchiectasis has been a neglected disease. Moreover, diagnosis and management of bronchiectasis is often challenging because of its varied etiology. Objective of today's webcast is to understand from the experts in the field on the various aspects of diagnosis and management of bronchiectasis, and also to know from them latest updates from Embark Registry of Bronchiectasis India. We are extremely honored to have eminent faculty members for this discussion today. We have Dr. Rajadhar and Professor Dr. James Chalmers with us, who have done immense work in the field of bronchiectasis. Dr. Rajadhar sir is Director at Department of Pulmonology at C.K. Birla Group of Hospitals, Kolkata. He is also Director for Training and Educational Initiatives and Indian Chest Society. He is Director, Training and Research at National Allergy Asthma Bronchitis Institute, Kolkata. Professor Dr. James Chalmers is Professor and Consultant Respiratory Physician at University of Dundee, UK. He is British Lung Foundation Chair of Respiratory Research at the University of Dundee and Honorary Consultant Physician at Nine Wales Hospital. He had chaired a number of international guidelines, including the current European Respiratory Society COVID-19 Task Force. He is currently Deputy Chief Editor of the European Respiratory Journal. His clinical and research interests are in respiratory infections, including pneumonia, COVID-19, bronchiectasis, and COPD. I thank both of them for accepting our invitation. Now, I hand over session to Dr. Rajadhar sir and request him to present on Embark India data. Thank you.
Hello friends, it gives me great pleasure to speak to you today on the occasion of World Bronchiectasis Month. We celebrated World Bronchiectasis Day on the 1st of July, and this meeting brought to you by CIPLA is to celebrate a month when we try and treat a disease which has in the past been treated as an orphan lung disease. Keeping this in mind, we did Embark India, about which I'm going to talk to you further, accumulated data, and tried to come up with robust guidance regarding the way forward for bronchiectasis management in this country. I start off in this talk with a definition, as you would do in most talks. And the definition that I have selected is from the ATS-ERS guidelines. So bronchiectasis is a chronic respiratory disease that is characterized by a clinical syndrome of cough, sputum production, and bronchial infection, and radiologically by abnormal and permanent dilatation of the bronchus. So you see, we have combined clinical symptoms in the form of cough, sputum production, and bronchial infection with radiological features in the way of permanent dilatation of the bronchus. So this is a clinical radiological diagnosis, something I will keep coming back to through the course of this talk. This is a paper we published in Nature Review, which looked at bronchiectasis as a disease process across continents. The first photograph there on the left, where my cursor is, and I hope you can see my cursor, looks at normal breathing passage. So you see smooth muscles lined outside, then you see a basement membrane, followed by an area of mucus, which lines the epithelial cells, blood vessels, etc. So deficiency, which results in bronchiectasis, can occur at 3 different levels. There can be loss of cilia, there can be destruction of the wall, and there can be increased mucus production. You can see this cartoon which shows destruction of wall, and destruction of the wall can result in ballooning of a portion of the wall, which describes various shapes in the morphology of bronchiectasis. And on the right on there, you can see the various shapes. There can be cylindrical, there can be varicose, and there can be cystic bronchiectasis. This is the seminal paper from Bronchiectasis India that we keep speaking about. This is a publication in Lancet Global Health, which we published in 2019, and it gives me great pride to be a first author in which I have got very respected colleagues, peers, together making up the Embark India data. The data is from no less than 31 different participating centers, and you can see the stars which are dotted across the huge country of ours, which is India. It was a non-interventional study, a study which involved adult patients. It was prospective and observational, as in we would not interfere or intervene in the process in which individual primary investigators at various centers deemed it necessary to treat their patients. And it still continues to be the first and largest Asian bronchiectasis data set, which demonstrates the geographic variation and inter-patient variability across this large country of ours. Data was collected between 1st of June 2015 to 1st of September 2017, and a total of 2195 patients were enrolled. Every aspect of bronchiectasis that you can think of, domains which include demographics, comorbidities, lab testing, lung function, exacerbations, disease impact, microbiology, radiology, treatment, and physiotherapy, all of these domains were touched on and were examined in course of this study. In order so that the demographics and the disease burden could be compared in various parts of the world, the data sheet that we used was similar to what was used in the European registry or in the US bronchiectasis registry. This helped us to mirror the findings in other countries and other continents, and I will show you some data later on during this presentation which compares the data sets, and the data sets were comparable only because the data sheet was similar. So let's look at the results from this initial phase of 2015 to 2017. The median age in the Indian population was 56 years, which was far lesser as compared to the rest of the world. It was a male predominant disease in India, again distinctive from the rest of the world, where it was mainly a female predominant disease. Predominantly, these patients were non-smokers. This is again from our Nature review paper, which looked at etiologies of bronchiectasis grouped by regions and population. And I won't go into children and adults. I'm an adult pulmonologist, and I hope you are too. I will show you disease etiologies and how they differ across developed and developing countries. So on the left, you can see diseases like post-infectious, idiopathic, COPD, asthma, ABPA, etc. are more common in the developing world, whereas idiopathic, immunodeficiency, primary ciliary dyskinesia, connective tissue diseases, alpha-1 antitrypsin deficiency, etc. were more common in the developed countries. Asthma COPD, however, is rampant everywhere, and the overlap population, or the population of patients who had bronchiectasis as a result of asthma and COPD, was no different between the developed and developing countries. So that gives you a global idea, an idea about how to think of etiologies in the developed and developing countries. So what were the etiologies in India? So again, Embark India, we found that the predominant etiology was post-TB bronchiectasis. and this accounted for 35% of the patients. Next was post-infectious, and next was idiopathic, both of which were between 20 to 22% of the total number of cases. Allergic bronchopulmonary aspergillosis was diagnosed in 9% of cases, 9%, which was a significant number by itself. However, this number was an underestimate because 50% of patients who were examined for ABPA, who were investigated for ABPA, came up with that diagnosis. So obviously the test was done when the clinician thought it was necessary, and hence the numbers were high. However, if you did ABPA testing, ABPA screening across the population of patients with bronchiectasis, especially severe bronchiectasis, the percentage would likely be far greater than the 9% that I have just mentioned. Why are we so fussed about the etiology of bronchiectasis? That's because in the differential diagnosis, in the causes of bronchiectasis, you have a few causes, quite a few causes, which are treatable. And in that list, you have combined variable immunodeficiency, allergic bronchopulmonary aspergillosis, mycobacterium other than tuberculosis, airways obstruction, inflammatory bowel disease, rheumatoid arthritis, and aspiration. Hence, what I mean is that if you treat these treatable traits, if you treat these etiologies, the underlying bronchiectasis would be better controlled or even get better in these individuals. And that's why identifying the etiology becomes so very important. In identifying the diagnosis of bronchiectasis, like we said to start with, the definition implies that you have an HRCT. However, in most cases, HRCT is the starting point. There are some patients, however, like the one in front of you, who, by the diagnosis, the etiological diagnosis is also apparent from a CT. So this is a patient with ABPA, and you can almost tell that from the CT itself because of the nature of the central bronchiectasis. You see the nature of the morphological nature of the bronchiectasis, lots of saccular, cystic, cylindrical bronchiectasis almost everywhere, but more centrally. The fact that you have mucus plugging, and there is high attenuation mucus, which fills up the entire length of the bronchus, which is almost pathognomonic when present of allergic bronchopulmonary aspergillosis. That's one CT for ABPA, which in some cases might be diagnostic. That's not to say you shouldn't investigate these people. You should, but you know the diagnosis even before you have investigated with other diagnostic modalities. This is Monier-Kuhn syndrome, and this shows an airway where the diameter differs by 3 centimeters at its highest between inspiration and expiration. So biphasic CT, inspiration and expiration, there's a difference of 3 centimeters. This is diffuse pan-bronchiolitis. On my cursor there, you can see multiple nodules scattered through both the lungs. There are areas of tree in bud interspersed throughout the lungs, especially towards the periphery. This is the disease which was initially thought to be present in Japan. This is, however, one of our patients, and we now know that pan-bronchiolitis is present throughout the world, albeit with greater numbers in Japan. This is a CT from a patient with Mycobacterium avium-intrace. You can see areas of fibrosis, you can see areas of cavitation, you can see the bronchiectasis. So NT, Mycobacterium avium-intrace, manifests either in the fibrotic form or in the cavitary form or in the fibrocavitary form. And when you get these forms on the CT, the thing that's uppermost in your minds is Mycobacterium avium-intrace. However, you will need to get a microbiological diagnosis here. So much of TB, post-TB bronchiectasis, you would think that the distribution is more in the upper lobes. Embark India showed that at least in the Indian population, that's not the case. As you see on the cartoon on the right where my cursor is, the bronchiectasis seems to be apparent in all lobes and zones of the lung, be that upper, middle, or lower. The most common form, including in the TB variety, is cystic dilatation of the bronchus. So that's the morphological variant which is most common in India, cystic bronchiectasis. The important facet, the important feature of the bronchiectasis India registry was the fact that if you looked at all exacerbations, there was 1.15 severe exacerbations throughout the year. This was not very different to what it was in the European or American population. However, severe exacerbations requiring hospitalization at 0.55 per year was higher as compared to other populations. So severe exacerbations in India mandate hospitalization in a higher number of cases. Airflow obstruction was the predominant physiological feature. So if you did spirometry in these individuals, a severe obstructive pattern was the most common, with about 35% of patients showing this. However, if you think about our MBBS teaching, we classify bronchiectasis as an obstructive airways disease. That's obviously not the case. 2/3 of patients did not have obstructive spirometry. In fact, 26.7% of patients had a restrictive spirometry with a low FVC. And interestingly, it was found that this low FVC population, the restrictive lung function population, were people who had post-TB bronchiectasis. So this was the greatest contributor in the restrictive lung disease basket. The other important and interesting feature about Embark India was the fact that sputum production was lesser in the Indian population. 60% or ballpark about 60% of patients did not produce daily sputum. And this was significant because hence the microbiology was less, as I will show you in the Indian cohort. So that's the microbiology. 59.2% of patients had one sputum sample taken in the year before the baseline visit. So about 60%, one sputum sample, which means 40% had no sputum sample done in the 1 year before they enter the study. The most frequent organism, albeit in lower numbers as compared to the rest of the world, but still most frequent, was Pseudomonas aeruginosa. However, striking in the Indian population was that there was about 10% who grew Enterobacteriaceae species. And when we say Enterobacteriaceae, the most common bacteria were E. coli and Klebsiella pneumoniae. So E. coli and Klebsiella pneumoniae, in a very small proportion, you see 1% of patients had Acinetobacter from the community. So that's interesting, worrisome. 1% is a small number, but Acinetobacter from the community is not good news. Organisms which seem to be common in the Western Europe population and in the US cohorts, like Haemophilus influenzae, Moraxella catarrhalis, non-tuberculous mycobacteria, strep pneumoniae, etc., were less in our population. However, we feel they were less because these are fastidious organisms, far more difficult to grow as compared to the gram-negatives, and hence it was more the microbiology backup which was at fault rather than these organisms missing from the Indian population. And we know this too today, simply because with the PCR test, we do find the Moraxella, strep pneumoniae, H. influenzae, etc. in much greater numbers. So that's our bar diagram, and you can see on the left, you have Pseudomonas and Enterobacteriaceae, which together consists of about 23.5% of the total number of patients, with the others following in smaller numbers. How do we treat these patients in India? Unfortunately, not very well. They get treated as per our previous MBBS teaching. The teaching which said this is within the broad basket of obstructive airways disease and should be treated as in asthma and COPD. That's not the case. Unfortunately, about 63% of patients received inhaled corticosteroids. About 56.5% of patients received a combination of an ICS and a LABA. Drugs like theophylline, leukotriene receptor antagonist, etc. were used as you would do in asthma and COPD, even though these diseases were not present. About 40% of patients had airway clearance techniques done on them. That's not bad at all. That's equal to the Western population. However, there's much to achieve. 40% meant 60% had no advice, and that's something that we need to change together. Evidence-based treatment like long-term antibiotics, macrolides for instance, or inhaled antibiotics, however, were prescribed in far smaller numbers. And when we say far smaller numbers, the numbers are less than 10%. So less than 10% of patients had prescriptions done of long-term antibiotics, low-dose macrolides, for instance, or nebulized antibiotics or inhaled antibiotics. And that again is a carry-home message for us to change going forward. How did the patient characteristics differ between India and the rest of the world? This is from our Korean counterparts who did embark. This is from the K-Embark study, which showed that the Indian cohort had a 10-year younger population as compared to the West. So 56 years, as we said, in India, 66 in Korea, similar age groups in Australia and Europe. The BMI was lowest in the Indian population. COPD and asthma were common both in the Korean and in the Indian population. Together, they would make up about 24 to 25% of the total number of patients. If you looked at the severe category, the most severe patient seems to be from the Australian and the Indian cohort. Hospitalizations, however, were the greatest by far in the Indian population. Pseudomonas was our commonest organism. However, other bugs were also present in the Indian population. We talked about Enterobacteriaceae, and in other populations, especially in Australia and Europe, the number of Pseudomonas was greater. Our commonest etiology was TB. We used a lot of ICS and LABA, less of long-term antibiotics and inhaled antibiotics, and these were all learning points from our registry. Let's finish off in the next 2 to 3 minutes talking about the follow-up results. This is unpublished data, which we hope to get published very soon. However, 1 year of follow-up at least in these patients showed that mortality was greatest with the factors enlisted in front of you and on the forest plot on the right. So age, infection with Enterobacteriaceae, especially Klebsiella, exacerbation in the past year, cardiovascular disease and diabetes as comorbidities, an increased MRC dyspnea score, and current smoking resulted in greater risks of mortality. If you looked at the etiology and the greatest risk of death, this was greatest in the COPD bronchiectasis overlap group. And I stress this, it's important to remember COPD bronchiectasis entails a greater risk, and hence it's important to look for bronchiectasis in your COPD population because they'll need much more hand-holding, they'll need far greater monitoring and more intensive treatment in trying to get them to survive longer. Hospitalizations obviously were also high in the COPD population, but also in the small number of rheumatoid arthritis bronchiectasis overlap patients that we had. You saw the predictors of mortality. These are the predictors of exacerbations. So prior exacerbation, Pseudomonas aeruginosa infection, diabetes, smoking, and MRC dyspnea score. So a lot of overlap between mortality risks versus exacerbation risks, understandably, are present, but prior exacerbation, Pseudomonas aeruginosa infection, diabetes, smoking, and MRC dyspnea score are predictors of exacerbation frequency. Exacerbations were not markedly different between etiologies. There was a small difference, COPD, TB, and post-infective bronchiectasis. So the post-infectious group generally seem to have the greatest risk of exacerbations and lower exacerbations in the asthma, ABP, and idiopathic bronchiectasis group. But these differences were small. Exacerbations were uniform, at least in the Indian registry. And this is a telling slide, an important slide which tells us why we should invest energy and time in treating this disease. Survival was high in both cohorts, be it the Indian and the European cohorts. More than 90% of patients survived beyond 4.5 years. However, they had poor quality of life, and simple things like mucus clearance techniques, evidence-based treatments that we spoke about, early diagnosis would be factors which would help you to treat these patients better. Mortality, as we said, was higher in India as compared to Europe. So the follow-up data from EMBARK India shows that gram-negative pathogens, aside from Pseudomonas aeruginosa, were associated with mortality. Pseudomonas aeruginosa, however, seem to be strongly related to exacerbations. Exacerbations were important. One exacerbation was a prelude to the next one, and one exacerbation in the previous year meant both a greater risk of exacerbation and a greater risk of mortality. You saw the data about diabetes, ischemic heart disease, so comorbidities are important, and we said current smoking is important. If you're a current smoker, the greater risk of dying from bronchiectasis. The fact that BCOS, the bronchiectasis COPD overlap syndrome, seem to be associated with worst outcomes in terms of exacerbation, in terms of disease burden, in the terms of mortality. And it's important to remember these guys because this will help you to support treatment decisions, prognosticate in these patients in an Indian context. I hope you found that talk useful, and I would be very happy to take questions. Thank you for listening in. You've just heard the EMBARK talk, the data, which is very relevant to our country. We are hoping to give you the follow-up data in the not so distant future. But what we'll do now is to discuss 3 cases, and you can put them in perspective in the context of the EMBARK India data. Dr. Vaishali Gupte told you that we have the good fortune of having Professor James Chalmers, who's the father of bronchiectasis globally, and he is going to discuss these cases with me as we go along. So what I'll do is I'll share screen now, and we'll show you these cases. They are real life cases. One of these is for the registry itself, from EMBARK India registry. The others are from day-to-day clinical practice, and hopefully they'll be relevant to you. So we start off with the first case, which is a 36-year-old lady who was diagnosed as having poorly controlled asthma, multiple hospital admissions with severe exacerbations. She otherwise had no other comorbidities and was not on any medications for any other medical conditions. She was a never smoker, a teacher by profession for the last 10 odd years, but struggling to attend her teaching schedule on a regular basis because she was so symptomatic from her asthma. She was admitted with us a while ago. This is 2017, I think, when she was admitted with the diagnosis of pneumonia. And she gave this classical history of coughing up plugs or paroxysms of cough that helped her clear her chest. So she would describe these as episodes when she felt as if there was mucus stuck at the back of the throat. She would need to cough. The cough would often be fruity. And then sometimes she would bring up these plugs, which were crystal-like. They were clear, they were tenacious, and they would come up in the shape of bronchial casts on certain occasions. A CT scan, which I'm going to show you in a minute, was showing central bronchiectasis, and we'll get these scans, get the opinion of Dr. Chalmers about these scans. She had eosinophilia on peripheral blood examination, and a diagnosis of ABPA was made in this clinical context. So this was a X-ray which she brought with her. This predated her examination, us knowing her. So March 2017, when she was stable, she had an FEV1 of 3 liters at the time, which was 85% of predicted. Her aspergillus IgE was 31 at this point of time. The cutoff here is 12, and her IgE, total IgE, was 1900. Even though these examinations were done at the time, because she was stable, she was kept on her ICS and LABA inhaler, and no specific treatment was given for her ABPA at this point of time. I told you about this particular episode when she came into hospital. At the time of discharge, she had a spirometry done, which showed an FEV1 of 1.6 liters. So understand 3 liters before, 1.6 liters after, an IgE which had jumped to 3000, and an aspergillus IgE which was 52.5. And this was diagnosed as an exacerbation of ABPA. So let me stop for a moment and get James with some comments. So James, you heard the history there. This is obviously not a perfectly worked up case. So I wondered what you thought about, let's go back to this slide. So March 2017, doing well. Someone saw this lady. She was obviously symptomatic, even though the spirometry was very good. An aspergillus IG which was raised, an total IG which was raised. She was left on, in spite of these investigations, she was left on an ICS and a LABA. So your comments about this, and then going forward about the exacerbation, and do you think there's a relevance about this drop of FEV1 and the rise in aspergillus IG titers and the total IG that I spoke about?
Yeah, so thank you very much. This is a really excellent case. It's a good illustration of the classic presentation of ABPA. So a patient with a history of asthma, thick tenacious secretions, central bronchiectasis. And these cases are extremely difficult. So when you see a patient who has grossly abnormal aspergillus serology, as this lady had in 2017, but clinically is doing quite well, it's difficult to then embark on a course of oral corticosteroids with all the associated side effects if the patient feels that they're doing well. I guess we've got to think about, though, that this is an inflammatory disease, and an inflammatory disease like asthma or ABPA puts you at very high risk of exacerbations. And so if you see somebody with grossly abnormal aspergillus serology like that, and they have very thick, difficult secretions and a lot of symptoms, even if they're not having frequent exacerbations, I would often initiate treatment at that stage in order to prevent them from having severe exacerbations and to get their symptoms under control, because you're trying to prevent then the development of progressive bronchiectasis and what ultimately happened to this lady, which is that the thick secretions block the airway tubes and you get reductions in lung function. The FEV1 here, I'm sure, is related to obstruction of the airways, and that the consolidation we see on the CT scan there, if we were to do a bronchoscopy, we would see that those thick tenacious secretions obstructing the airway tubes.
Sure. And you said starting off steroids at that point, James. So just a quick, we'll come back to this later on, but sort of what makes you decide between starting off with a steroid versus starting off with an antifungal and a steroid? And sort of how would you position adding in an antifungal in patients with ABPA?
Yeah, very good question. So we debated this intensively in the British Thoracic Society bronchiectasis guidelines, because we had a table of some of the world's greatest experts in this topic, and all of us had a different regime and a different approach to treating. And I think that reflects that we don't have enough large trials in ABPA. Some of the best trials come from India, as I'm sure you know.
Sure.
But the best data that there is on itraconazole or other antifungals is as a steroid sparing agent. So in the majority of patients, I start with steroids alone, unless the aspergillus IgG is very high or I have very profuse growth of aspergillus, suggesting that there's a contribution from excessive aspergillus in the airways. Others start itraconazole or other antifungals up front and try to then wean down the steroids more rapidly. I tend to introduce antifungals later in the majority of my patients if I'm having difficulty weaning them off oral steroids. But I'm not sure that anyone knows which of those is the best approach as yet.
Sure. So James, I actually do what you said, which is a large majority of my patient actually would not go on to an antifungal because weaning the steroids off with the period of stability doesn't prove to be very difficult. But later on, when you wean the steroids off, often they exacerbate again. And when you're restarting steroids the second time or the third time around, maybe you would probably start off with a steroid and antifungal combination and itraconazole combination. Not much to choose between itraconazole and voriconazole, right?
Yeah, that's correct. Most of the data is with itraconazole. So the classic New England trial was done with itraconazole. But indeed, I don't think there's any evidence to choose between them.
Sure. I'll move on. So March 2017, September 2017. So you saw one X-ray a little while ago. That was September 2017. That was the X-ray this patient came in with, and then collapsed the right upper lobe, which is what you see on that chest X-ray. James was talking about a bronchoscopy. I'll show you pictures of bronchoscopy for this lady. So she had a bronchoscopy done, and that showed the thick tenacious secretions, the mucus plugging, which resulted in the drop in FEV1, which James described a little while ago. And this is in January 2018, but there's a little bit of collapse which is left behind in the long term, but most of the right upper lobe has come up again. So that's the CT, and I want you, James, to comment about this CT. There's not many cuts, I'm afraid, but what we have is what we have. So if you can talk about the CT and what's relevant for our listeners.
Yeah, so I mean, I'm sure all of our listeners can see that this is really quite severe central bronchiectasis. You can see the effectively cystic change with some varicose change, very much so in the right lung. This is very severe bronchiectatic change compared to what I see in the majority of my ABPA patients, and perhaps suggests that the disease predated the 2017 initial diagnosis of ABPA, because this is, as I say, very severe cystic disease. When you see really severe cystic disease, you've always got to think about the differential of severe central bronchiectasis, which is tracheobronchomegaly, Munier-Kuhn syndrome. But there you see a grossly dilated trachea, which isn't evident here, and also the left lung looks normal. So this is very much a case of unilateral, or predominantly unilateral on the cuts that we can see, severe central bronchiectasis. So very much consistent with ABPA.
Right. So this lady, we said, James, was very symptomatic for about 2 to 3 years, multiple courses of oral steroids, multiple courses of antibiotics, and went along with a diagnosis of GINA 5 asthma for a long period of time, which is something I guess we get quite a lot, at least in this country, because people don't routinely check for ABPA, which is something that we probably need to ask our listeners to do, at least in cases of severe asthma. The PGI Chandigarh group actually advocate doing an ABPA screen in every patient of asthma. I have to confess that's not something I managed to do in all my patients, but definitely in a GINA 4 or a GINA 5 asthmatic, that's something that I would advocate and screen for.
I think that's right. So we do it in every patient that has bronchiectasis, whether it's central or not. And in somebody who's got severe asthma, if you're thinking about high dose corticosteroids or biologics or any of those sorts of interventions, they must have been screened for ABPA, because it's something you don't want to miss.
Sure. So things got worse. This is about 8 months after the previous admission. And this lady came into hospital severely breathless. And you see that there's a whiteout on the left side. This is likely a collapse on the left, probably a plug that's lodged in the left main bronchus. This was the sputum that this lady was producing. You heard James describing this as very thick, tenacious plugs, thick, tenacious sputum. And you can see that it's sort of stuck to the side of the pot that's visible on the slide on there. So that's classic. This does not belong to this lady. That's taken from the net, but that's what the sputum would look like in patients with ABPA. And these are real pictures. You see that's the left main bronchus on there, and you can see the thick plug projecting out from the left main bronchus. This is after the left main bronchus has been cleaned. There's been extensive bronchial toileting that's been done. This lady actually needed a cryoprobe to actually remove these. The plugs were so difficult to dislodge that you actually needed a cryoprobe to try and dislodge these plugs, which is what we managed to do at the end. Sorry, the pictures aren't great, but that's all we have. And this is what showed up on microscopy. This is bronchial tissue. This is the tissue that we debulked with the cryoprobe. And you can see Aspergillus fumigatus in both the bowel and the tissue that we dislodged, or the solid mucus plugs that we dislodged from the lady's airways. So classic Aspergillus. Anything to say at this point, James?
No, just a terrific example of ABPA, that thick tenacious secretion. So eosinophilic inflammation drives massive production of mucins. So you get this very thick dehydrated sputum that defies gravity. So you turn the sputum pot upside down and it doesn't fall to the ground. So this is a classic presentation, a classic case, and that's the biology of why it behaves like that.
Sure. So that's the patient. So let's sort of finish off. I'll go to case 2 in a moment, James. But so this lady, she's had 2 exacerbations now. This is 2018. Post 2017, so September 2017, this lady got put on oral steroids. She was on oral steroids when she had this exacerbation. The dose at that point of time was prednisolone 5 milligrams a day, and she exacerbated that point of time. When we sent her home on 30 milligrams of oral prednisolone, but added in the itraconazole at that point of time. The lady had another exacerbation about 6 weeks down the line, for which she needed to be hospitalized again. There was a right lower lobe collapse this time. We again did a bronchoscopy. There were similar pictures. We managed to clear the right lower lobe again. The lung expanded, and she went home on a similar combination again. The exacerbations were clustered so close together. And then through 2019, early 2020, she remained stable. She got weaned of the steroids sometime around 2019 October, and continued on the oral itraconazole till about the beginning of the pandemic. So beginning of the pandemic in India, which is April, May, and continues to be stable till date. So I wondered what your thoughts were. Would you have treated her similarly, any different? She's still getting treated for her asthma, obviously, with the ICS and the LABA. We are lucky that she's not exacerbated, and maybe it's also because people have stayed in lockdown and stayed away. Triggers have been less, so she's remained stable. But your thoughts and what the future course might be in this lady?
Yeah, so it sounds as if she's been managed extremely well, and this is very much consistent with guidelines, which is the use of steroids, itraconazole as a steroid-sparing agent, and always explaining to patients that this can take a long time to get things under control. So patients may be on steroid for long periods of time. I guess what I'm doing a lot with my patients now is, if I'm not able to get them off steroid over a 6-month period with the addition of itraconazole, is thinking about the biologic drugs that we now use for severe asthma. So there is data both for anti-IgE and for anti-IL-5 or anti-IL-5 receptor therapy in people with refractory ABPA. So I tend to think about those and at least have the discussion with the patients if I can't wean them off oral steroids after about 6 months. And I've had really fantastic results with many of my patients getting them off steroids with the biologics. There's obviously a big cost implication to that, but the long-term impact of being on steroids for several years is just something to think about in refractory cases of ABPA.
Sure. So, James, I'll sort of hold that thought for a minute. So we had discussed at that point of time about mepolizumab with this lady. The challenge we have with omalizumab is the dosing. So we did anecdotally give a dose of 300 milligram to patients with ABPA prior to when we had anti-IL-5 and anti-IL-5 receptor antagonist. And now I guess the scope is more with mepo. I haven't seen the data with Benrali, but I guess what would you normally use? Would you use mepolizumab because that's a fixed dose that you can use? Or would you go for a fixed dose of omalizumab in these patients?
Yeah, so I've actually used both. So as you know, eosinophilia is found often in ABPA, but it's not universal in ABPA. So you have patients with ABPA who have grossly elevated IgE and specific IgE, but a normal eosinophil count. And so those I tend to go for omalizumab at the fixed dose, as you said. If there is eosinophilia, I go for the anti-IL-5 rather than the anti-IgE for the reasons that you've explained.
Sure.
But it has to be based on the biomarkers.
Sure. Okay. Right. So we'll move on. We'll do case 2. So this is a reasonably mundane case, but something that you would probably see in your clinical practice on a more regular basis. So this is a 54-year-old gentleman who used to live in Asansol, which is, as you know, in the eastern parts of the state, the coal belt of India. He had relocated, visited my OPD as a new patient on the day when he was unwell, and got a phone call from someone, a colleague I know closely, who said that he knew this gentleman well, needed to be reviewed early. So came into clinic with the complaint that his cough had gone up significantly, was pretty bad, and he had difficulty breathing, especially when he was coughing. And when you went further on, he said he was suffering from cough, expectoration, and breathlessness. The current episode had lasted about 10 days. There was initial fever, which had subsided after taking 3 days of antibiotics prescribed by his local physician, and he stopped the antibiotic at that point of time. The breathlessness was better. The sputum dried up, but he still had a dry cough and a wheeze, which was left behind. His symptoms worsened, which prompted him to come and show us in our outpatients department. So we're still talking about this case, which is pre-COVID. This is from 2019, because otherwise, one of the first things that would come to mind if this was sort of post-2020 is whether this man has COVID or not. So the known patient with COPD with multiple comorbidities who had been experiencing breathlessness for the last 15 years, 2 hospitalizations in the past 2 years. On one occasion, he was in ICU for about 5 days before he was shifted to the wards. During the time in intensive care, he needed non-invasive ventilation for gradually reducing periods of time. He had respiratory acidosis at that time. He had significant comorbidities in the way of hypertension, ischemic heart disease. He had had a CABG done about 3 years ago. If you asked him about his baseline symptoms, he was still quite symptomatic. Cough, wheeze. There was about once or twice during an average week when he would wake up coughing. He often produced cough with yellow phlegm, which was large in amount. He had never had hemoptysis. His normal exercise tolerance was 200 yards, but when he had an exacerbation like the one he came in with, he could hardly walk a few steps. He, however, struggled at baseline to climb up 1 flight of stairs. He had a very long history of smoking, so 50 pack years of smoking, which he had stopped about a year ago during his last admission. And he had significant coal exposure. I said he lived in Asansol in the coal belt. So he worked in an iron ore factory and had substantial exposure to dust. That's his current list of medication. So as always, the cardiac medications come on top. So the ACE inhibitor, the beta blocker, the diuretic. He was an ICS and a LABA, so standard treatment. He was also on a LAMA, the tiotropium, and he took levosalbutamol on an SOS basis. He, however, did not take his tiotropium regularly. He said he felt no comfort taking the tiotropium. Instead, he would use up 1 canister of levosalbutamol every week, but he was regular with his salmeterol-fluticasone combination. He would take 2 puffs twice a day, and he did that religiously. But for his symptoms, he needed large amounts of levosalbutamol as rescue. These were his physical examination at the time of admission, and I think the important things there are that he's febrile. So that's about 38.5 degrees centigrade, James. So 101.5 degrees Fahrenheit. He was unable to speak in full sentences, audible wheezing, alert and orientated, with no accessory muscle use, but he was significantly breathless. He walked in and he had to sit for a couple of minutes before he could utter his first few words. He had a barrel-shaped chest. He had reduced air entry and then some amount of wheezing, which was heard on auscultation. His heart sounds were fine. He had tar staining in his nails. He was clubbed, and his pulse oximetry showed that he had an 86% saturation in room air. You see his corresponding ABG on there. So he had respiratory acidosis. He was significantly hypoxic. So type 2, acidotic type 2 respiratory failure, respiratory acidosis, see what you see on there. He had a raised white cell count. His absolute eosinophil count, and we'll come back to this and ask James on this a little while later, but his absolute eosinophil count when he was stable 6 months ago was 180. His chest X-ray, which I'll show you in a minute, showed some infective changes. And his CT scan, which was the first CT scan he did not have CT scans done before, even during exacerbations. But on this admission, his CT scan showed bilateral lower lobe bronchiectasis and some emphysema, which are also pronounced in the lower lobes. That's his echocardiogram. Not very remarkable, especially given the fact that he's had a CABG done, a long history of ischemic heart disease. So a lowered ejection fraction at 30%. With a grade 2 diastolic dysfunction, but importantly, the raised pulmonary artery pressures more or less consistent with the degree of COPD that this gentleman had. That's his spirometry. So you see that he's got a ratio which is by definition obstructive. So 60% ratio. And then he's got an FEV1 of 1.21 pre-bronchodilator and 1.38 post-bronchodilator, which again was about 60% predicted. And you can see the scalloping of the curve, the obstructive flow volume loop, which is classic on that particular slide. And that's the CT. And I'll stop there. Before you tell us what we feel about the CT, James, your thoughts about this case, someone with known COPD long-term, producing large amounts of sputum, very symptomatic. Do you think we missed the boat a little in delaying the CT scan? The CT scan should have been done much earlier, because then maybe the exacerbations could have been stopped. So your comments about the case, what's happened till date, and then maybe a comment about the CT.
I think this is an excellent case. So we see bronchiectasis commonly in people with COPD, and there's no question this patient has COPD. They have a big smoking history. They have emphysema on CT. So this isn't a case of misdiagnosis. But I think it comes back to what you said earlier about, patients who are doing really badly. We should be thinking about, is there something else that we're missing, a treatable trait like bronchiectasis? And so this is a patient who's having frequent exacerbations with large volumes of sputum. As soon as you hear those two things in combination, alarm bells should be ringing for you in a COPD patient going, that sounds like bronchiectasis. Because in moderate to severe bronchiectasis, which is what this gentleman has, up to 50% of patients in research studies have bronchiectasis on CT. And it's something that will change management. So I do think we should be doing CTs earlier in frequently exacerbating COPD patients, particularly scenarios like this.
Sure. Let me quiz you, not about this case, James, but we seem to be doing far more CTs now, unlike this particular case. So you have someone with COPD who does not have the classic productive sputum production that we described here, but you happen to do a CT, a clinician happens to do a CT, and you incidentally pick up a little bit of bronchiectasis, which is not uncommon. However, the patient has moderate airflow obstruction, reasonable control on an ICS LABA and a LAMA maybe, or a LABA plus a LAMA, dual bronchodilation. What would you do about the bronchiectasis here if it's a sort of an incidental finding on a CT rather than being symptomatic?
Yeah, so it depends on the extent of the bronchiectasis, I think. So we now know from the SOB-June study from the United States that if you scan COPD patients that have no sputum production, you do sometimes pick up pseudo-bronchiectasis, which is where you have the blood vessels reduce in size because of pulmonary hypertension, and it looks like they have bronchiectasis. It looks like they have the signet ring sign, but it's due to changes in vascular diameter. And so in those situations, you don't need to do anything about the bronchiectasis because they don't really have bronchiectasis. If you see a scan like this, though, it's a different story because this is real bronchiectasis. And so that would be a situation where you would be taking an intensive history about sputum production. And we know that a lot of patients with bronchiectasis don't produce large volumes of sputum. See the EMBARK India data and the proportion of patients, but they're still at risk of exacerbation. And so it may lead you to do further investigations such as a bronchoscopy, or to be more aggressive with treatments such as prophylactic antibiotics if indeed patients are having frequent exacerbations.
Sure.
So I think don't ignore the finding of bronchiectasis, even if the patient's symptoms are not classical copious sputum production. Sure.
And I have another question, James. So suppose, this particular patient, this is a lot of bronchiectasis, this significant bronchiectasis. So we also know this patient has got COPD. So in this clinical scenario, you just infer that this patient has the COPD bronchiectasis overlap, or would you work this patient up for bronchiectasis and look for other etiologies also?
Yeah, that's a really important question. So my advice is don't stop at the finding that this person just has bronchiectasis due to COPD, because patients can have as many diseases as they want. And so there's no reason why this person can't have another reason why they have bronchiectasis. Immunodeficiency is very common in this population. And that can either be a primary immune deficiency or antibody deficiency because of recurrent courses of steroids. I see a lot of COPD patients who get recurrent courses of steroids. They develop antibody deficiency as a result of that, and then they develop bronchiectasis because they start to get more bacterial infections due to a secondary immune deficiency. So you should, with a scan like this, you should investigate them the way you would with any idiopathic bronchiectasis. Go looking for those underlying causes.
That's an important message for all of us. I think we shouldn't sort of say that this is, we've got an etiology, it's COPD, bronchiectasis overlap. Look for other etiologies is important. And sort of before we move on, one last question, James. So I had just mentioned from the follow-up studies that this cohort of patients, at least in the Indian registry, seem to have the greatest morbidity, the most number of exacerbations, and even the greatest mortality. So you feel that we should actually actively seek out bronchiectasis in patients who've got severe, maybe Gold D COPD as a matter of routine, rather than just speaking about sputum, large volumes, the bronchiectasis phenotype. You also mentioned the fact that these patients, the Indian cohort, seem to produce less sputum, at least in the India registry.
Yeah, so even in my practice, so even in the UK, if I have a Gold D COPD patient who's having lots of exacerbations, perhaps hospital admissions, I would go looking for bronchiectasis even if they don't produce large volumes of sputum, because it's a potentially treatable issue. And there are phenotypes like non-tuberculous mycobacterial infection that classically don't cause copious sputum production, but are still important to identify and treat in a difficult to manage COPD. Gold D. So yes, I think we should be proactive in looking for this in either asthma or COPD patients that are difficult to manage.
Right, great. So we'll crack on. So this patient is now admitted. He's got increasing symptoms after hospitalization. You saw the low oxygen saturations, the type 2 respiratory failure, the respiratory acidosis, and all of this combined, he came into hospital, went into intensive care with a diagnosis of a severe exacerbation of COPD. He got put on non-invasive ventilation. He had standard treatment that you would prescribe for someone who comes in with an exacerbation. He was treated with antibiotics, steroids, nebulization. He had a sputum sent off, which was negative at this point of time. He went home. However, he remained hypoxic when he went home. He went home on 2 liters of oxygen with a nasal cannula. And we asked him to come back in 2 weeks' time to get reassessed again. We advised him pneumococcal vaccination prior to discharge. He also had his influenza shot given at this point of time. And he was optimized for outpatient care. That's not something we're going to discuss today, because we are here to discuss about bronchiectasis, not about COPD exacerbations. But any points, anything else to add, James, about this particular case before we move to case 3? Any messages?
Yeah, I guess the one thing that was missing from the whole story, which would be really high up in my mind, is the sputum microbiology. Sure. So if, in a bronchiectasis and COPD overlap case would be to know, with that copious sputum production, do they have Pseudomonas? Do they have Klebsiella? Do they have another gram-negative organism that we could treat and we could target? We talked briefly about the eosinophil count, and this patient's on very high dose ICS. Perhaps thinking about in a bronchiectasis patient, we start to think about maybe de-escalating that because of the potential that promotes bacterial growth. Again, the sputum microbiology would help us with that. And as an aside, I noticed it's a patient who uses a lot of beta agonist, but is also on metoprolol. So we're not here to talk about COPD management, but there's a few things in that case where I think care could be optimized.
Yeah. So the sputum, I said it in passing up. Yeah. So I said that the sputum was negative. But just going back, not something mentioned in the slide, but the guy came in on a course of levofloxacin when he came, and his GP had prescribed him a course of quinolone. So fair point. I think the sputum needs to be checked again going forward when the patient is more stable. And I think very important about the inhaled corticosteroid, I should have asked that myself. The fact that this patient had a low eosinophil count, has bronchiectasis, and probably should go home on dual bronchodilation rather than an inhaled corticosteroid when they went home. So I think that's very, very important and relevant bits of information. So last 10 minutes, let's crack on and we'll discuss case 3. This is a 65-year-old lady. This is from more recently. She was admitted with an exacerbation of dyspnea, productive cough. So this is about 2 years ago. So bit more than that, 2.5 years ago. This is just preceding the pandemic. She still follows up with us, but got admitted 2.5 years ago, pre-pandemic, with an exacerbation of dyspnea and a productive cough. When you quizzed her further about her history, she describes that she's always had a cough. She produces lots of phlegm, purulent sputum with the phlegm, and she had had recurrent episodes of lower respiratory tract infection. The symptoms got worse till about the age of 20, 22, and then they got better for a period of time. At 50, her symptoms worsened again, and she would describe a couple of exacerbations every year when she got treated with a course of antibiotics, sometimes a course of oral prednisolone for about 7 days. The symptoms would get better, but there was hardly ever a time when she would be asymptomatic. She was, however, reasonably well nourished. She had nasal obstruction and signs of chronic sinusitis, which was documented by an ENT doctor about 2 or 3 years ago, but there was no specific treatment that was given for this. She was clubbed, significantly clubbed, and if you listen to her chest, she had good going coarse crackles, especially at her lung bases. And I'll show you the X-ray and the CT, and I'll sort of wait for your comments, James. So that's the X-ray, and that's the CT. Again, I've only got one cut, but I can see James smiling. So we'll, James, your comments first about the case, what your thoughts were with that history, and then your thinking about the X-ray and the CT.
Yeah, so a wonderful case and illustrates a number of really important points. This is somebody with bronchiectasis presenting in later life, but who's had symptoms since childhood. So what are you thinking if somebody's got symptoms since childhood? What are the causes of bronchiectasis that can emerge from childhood? So congenital causes related to genetic diseases, cystic fibrosis, primary ciliary dyskinesia, Muir-Kuhn syndrome, which I've mentioned already, or often patients have severe pneumonias in childhood that cause a post-infective type of bronchiectasis. So those are the kinds of things that I'm thinking about. And the symptoms that the patient presents with give us some clues. So they've got sinusitis, severe upper airway symptoms, which can go with either cystic fibrosis or PCD, but they're well nourished, so it sounds as if they don't have pancreatic insufficiency. And usually cystic fibrosis causes such a severe condition that patients will present long before the age of 65. And then the X-ray makes the diagnosis for us because the patient has dextrocardia. And so the combination of bronchiectasis with dextrocardia, you don't need the CT. You can say this is cartaginous syndrome, one of the presentations of primary ciliary dyskinesia. The bronchiectasis in that condition is usually in the lower and the middle lobes, and this patient had crackles in the lower lobes. You can see the location of the bronchiectasis here. Predominantly cylindrical bronchiectasis. The patient's done quite well to get to adulthood without more severe bronchiectasis than this, and having, it sounds as if, done relatively well up until her 50s. And that's, so the phenotype of primary ciliary dyskinesia can be quite variable because it's caused by more than 50 different mutations or 50 different genes that are mutated. And so there are very severe forms that present with severe neonatal distress and symptoms in childhood, but there are others that present insidiously in adulthood because the ciliary defect is more mild. An important thing to remember is that although this is a classic case with dextrocardia, only around 50% of cases of primary ciliary dyskinesia have dextrocardia. And so many of your patients in your clinics, if they've had symptoms since childhood, may have PCD. But it's often missed if it doesn't present with dextrocardia. So I think we miss a lot of PCD.
Right. So I think that's very pertinent. And let me go to my next slide. And I think that's one of the things that I would want to ask you. So poor lung function, so an FEV1 of less than a liter, obstructive spirometry. And then looking through the literature, there's a lot of mention about doing transbronchial lung biopsies, and then examination under electron microscopy for ciliary motility, the genetic mutations that you spoke about, James. How important is that in a case like this to clinch the diagnosis, or is there any other reason to actually do a biopsy to establish the diagnosis in these cases, James?
Yeah, so there's no need to do a bronchoscopy and to do a biopsy in the lung. So the cilia are expressed all the way along the respiratory tract. And so in fact, you can just take a brushing of the nose if you want to look at the cilia under the microscope in order to confirm the diagnosis. So the guideline recommended screening test is a nasal nitric oxide, because if that is low, that's highly suggestive of PCD. It doesn't make the diagnosis. No one test is perfect. If you have the facilities to do it, taking a brushing and looking at the cilia beating under a microscope, high-speed video microscopy can be diagnostic. And then electron microscopy can support that diagnosis, although it's important to remember that some PCD variants can give you normal electron microscopy. So again, emphasizing it's a diagnosis not made by a single test, but by looking at all of the tests together with the clinical picture. Here, if you had a low nasal nitric oxide and that CT and that clinical history, I think most of us would be happy to call that PCD because it's such a classical presentation. It's more difficult when it's not such a classical presentation and you do need those combinations of tests. A big problem is that those tests are not widely available and expert staff to perform those tests are not widely available. But I think it is important to make a diagnosis of PCD. It changes management in terms of your airway clearance. You're much more aggressive with things like hypertonic saline. But there's also family counseling aspects to this because it's a genetic disease. Other members of the family may be affected and therefore may need identification and early treatment.
Sure. So, James, I've got a cohort of patients with Cartagener's syndrome, the classic dextrocardia. When I say a few cases, about 7 or 8 cases, all of them are above 50 and have done reasonably well to reach that age. I wonder the diagnostic tests, so the nasal nitric oxide, looking at the nasal cilia motility under electron microscopy, etc., would also be similar as you would get it in younger individuals if they are past 50? Or in that cohort of patients, you should actually be doing something like a lung biopsy as was suggested in this particular patient?
No, so the beauty of the test that we do with the nasal brushing is that we grow the cells for 6 weeks in antibiotics and steroids so that the cells are very happy. So no matter how badly diseased the tissue is, and it often is really badly diseased in these patients, you can rescue it by growing them up at air-liquid interface with that methodology. So there's actually no circumstance where you need to do a lung biopsy for this diagnosis. It can all be done with tissue from the nose. So it's not an easy thing to do, but these tests are a well-established way of doing it.
Sure.
Genetics is getting better, and so in the future it may well be that you don't need to do the cilia function test because the genes are so well defined that in fact a genetic test can be done initially. But at the moment, the problem is that a lot of the genes haven't been discovered yet. And so a negative genetics doesn't mean the patient doesn't have PCD.
Sure. Great. So just to finish this case off, so this lady was treated with oral antibiotics. She was given a flutter device to carry home. She was taught postural drainage. And in spite of this, she continued to have about 2 to 3 exacerbations every year. She lived on for about 6 or 7 years after. She came in with gradually worsening hypercarbia and hypoxia about early 70s. And then she died of a prolonged ICU admission where she had respiratory acidosis. She got ventilated, however, did not recover and passed away peacefully over a period of time. I reckon she did reasonably well with the amount of disease that she had. Any last comments, James, about patients like this? Do you think sort of getting to the 70s is more or less an achievement? That's probably the best result you could have, even with good postural drainage, physiotherapy, etc.?
Yeah, I think it's a very sad outcome. I think you're right that she was diagnosed at the age of 65 with quite advanced lung function deterioration and FEV1 of only 0.7. So I guess you would say at that stage, a lot of the damage had been done. So I think it emphasizes why it's important for us to try and identify bronchiectasis early. There was almost certainly opportunities in this lady's childhood or in early 20s to have identified that she had something like this and to prevent the FEV1 to getting to that stage. With macrolides and good physiotherapy, it sounds like she had exemplary care, but it was just too late to change the trajectory of her disease. So I'm always saying that we need to be really proactive in trying to diagnose bronchiectasis early, and that would also be nicely illustrated by this case.
Yeah, and you made a very important point, James, that while she did live beyond 70, she actually had poor quality of life. She had recurrent exacerbations, her mobility was very restricted, she produced large volumes of sputum, and that probably emphasizes the importance of physiotherapy, the flutter devices, etc., that you spoke about, along with the low-dose macrolides, which she got prescribed later on. So we'll finish off with a few comments from you, James. To start with, I presented some of the follow-up data from EMBARK, and we spoke about the fact that certain disease etiologies like the COPD bronchiectasis overlap seem to predict a worse prognosis. They seem to indicate more exacerbations, more mortality. We spoke about Klebsiella being an important factor, the entire Enterobacteriaceae group being an important predictor of poor prognosis, and the fact that along with Pseudomonas, it was a very important player in the Indian population of patients with bronchiectasis. So as we go forward, managing bronchiectasis, thanks to our composite efforts, your guidance, James, I think we have become more cognizant of this disease process. People think about bronchiectasis. There are meetings like this, which get held on bronchiectasis, which never happened 5 years ago. So certain important pointers that you would like to tell us from a tertiary care center, one of the best centers in the world treating bronchiectasis, what we should do differently, what we should think going forward, keeping in mind the EMBARK India registry and its findings.
Yeah, so I think these are three really wonderful cases that illustrate the importance of what you said, Raja, which is that we don't just stop at the diagnosis of bronchiectasis, but we need to think about the phenotype of our patient. And EMBARK India has given us brilliant data on the phenotypes of the patients in an Indian setting, which includes the COPD overlap patients that have greater exacerbations and worse prognosis, ABPA, which is very common in an Indian setting and needs to be proactively identified and treated, and then that final case of Cartagener's syndrome, where there were opportunities for earlier diagnosis. All of that emphasizes that we don't just do the CT and stop at a diagnosis of bronchiectasis. We need to ask ourselves, what's the underlying condition? What additional tests do I need to do to identify those underlying conditions, those treatable traits, so that we can add things into the management beyond just physiotherapy and antibiotics. And then the microbiology. So for every patient who's able to expectorate a sputum, let's get a microbiology, because Enterobacteriaceae, which is very common in an Indian setting based on the registry data, and Pseudomonas, both associated with a worse prognosis, again, should be triggers for us to introduce those low-dose macrolide or the inhaled antibiotics that will control the infection, reduce the exacerbation frequency, and improve the long-term outcome. So I think the registry data has given us fantastic pointers towards those high-risk phenotypes. And so the message is diagnose bronchiectasis, but don't stop there. Identify the phenotype so that you know which treatment to institute, because your patients will do better as a result.
Thank you, James. Wonderful messages. I think we've run out of time. So thank you very much for taking the time out. I know it's very, very busy times for you, James, with World Bronchiectasis Day around the corner and the World Bronchiectasis Conference. So look forward to better sessions in the future. I'm sure we'll collaborate more and produce more EMBARK data as we go forward, globally and from India. Thank you very much for spending the time with us, and I hope to see you soon.
Thank you.
I thank Dr. Rajadhar sir and Professor Dr. Jane Chalmers sir for this wonderful case-based discussion. I also thank Dr. Rajadhar sir for providing latest updates from EMBARK India data. I am sure this provided robust guidance to our audience on diagnosis and management of bronchiectasis. I thank our audience for spending their valuable time with us and also for their active participation. We are sure that your queries will be addressed by our faculty in a few days' time. We will come back to you again with many such informative sessions. Signing off now. Thank you.